Good afternoon, everyone. Welcome to the Pediatric Anesthesia track. I have with me 4 consultants from KK Hospital who will be sharing with you their experience in 4 different but interesting aspects of pediatric anesthesia. Let me introduce them. The first one is Lee Sumin. Hi, Lee. Sumin.
Hi.
The second speaker is Dr. Satish Reddy. Hi, Satish. The third speaker is Lee Shuing. Hi, Shuing. And
Hello.
last but not the least is Dr. Serene Lim. Hi, Serene.
Hi.
Hi. First, I would like to invite Dr. Sumin Lee for her talk on anesthesia for pediatric ENT surgery. Over to Sumin.
And thank you for attending this talk. My name is Sumin. I'm from KK Women's and Children's Hospital, Pediatric Anesthesia Department. And today we'll be talking about anesthesia for pediatric ENT surgery. So disclosures. This track is kindly sponsored by KABI FRESENIUS, but otherwise we don't have any other disclosures, except that we work with a great team of ENT colleagues in our hospital, who you can see in this picture. So today's agenda, I have 20 minutes to briefly go through these areas. And we're just going to talk about what children are like these days and what are the bread and butter standards in pediatric ENT surgery. We'll comment on some of the variations that we have on conventional techniques that I'm sure that many of you are quite familiar with. And also to have a peek into the advances of surgeries and technologies in the ENT field. We'd also like to go through how we are 2 specialties that are partners in airway management and what we should look forward to in the future. So firstly, children. What do we see in ENT? We see a lot of congenital anomalies. So for example, on the right side, we have a bilateral choanal atresia. And also we have patients who have anatomy that is still developing in many different ways, not just in size, but also in form and structure. And of course, as we all know, hypoxia is our greatest enemy to all of us, and that in these particular procedures, that it can be particularly pernicious and lead to arrest situations. And in pediatrics, we're all aware that everything is very small, collapsible, and basically fiddly. As opposed to on the bottom right-hand side, you can see laryngomalacia, and on the top right, you can see a Pierre-Robin sequence patient with a very receding chin. So compared to adults, we don't have as high a prevalence of head and neck tumors, and also the regenerative ability of children is also harnessed in some of the procedures. The other thing that we see quite often is upper respiratory tract infection, which can lead to quite significant cancellation rates for surgeries. And of course, we're all aware that with the URTI, it leads to PRAEs, otherwise known as perioperative respiratory adverse events. And the ones that we are most concerned about, of course, are like laryngospasm, coughing, bronchospasm, oxygen desaturation, and obstruction from secretions. So at the moment, the current guidelines still advocate at least a 2-week interval of symptom-free from URTI for patients before they can proceed for their general anesthesia. However, we must be aware that sometimes the priority of the surgery may be considered over the risk of the PRAE. For example, you may need to do a tonsillectomy to prevent the patient from getting more frequent URTIs. So this needs to be a shared decision-making model with the surgeons. Of course, we know that we want to prevent all this so we don't get these situations. So what type of mitigation? We should choose our airway device properly. So LMA that is used, or supraglottic airway devices that are used properly, are shown to be superior over endotracheal intubation. Of course, with less manipulation of the airway, there's less chance of PRAEs. And an IV induction will also have less chance of these complications compared to inhalational. And if you have to choose the maintenance, a TIVA, total intravenous anesthesia, technique with propofol would be preferable over sevoflurane, which in turn would be preferable over desflurane. So other pediatric issues, we all know what OSA is. It is actually probably the main category under the sleep disorder breathing section. And as you can see, there are many issues that I'm sure you're all aware of. Apart from the PRAEs that we've mentioned, our patients with OSA are quite sensitive to opioids, so we must decrease the dose compared to normal children. And also that these children tend to have behavioral issues as well and learning dysfunctions, which can be related to this condition. So it may be important for them to have their surgery. These patients have also been associated with increased systemic inflammatory response, and if it's been long-standing, also cardiac sequelae. And to be aware that OSA patients may also have other comorbidities, for example, syndromes or congenital anomalies, which lead to these conditions. The gold standard for pre-assessment is still the sleep study or the polysomnography, but it's not mandatory. But you would probably want to select it if your patient is very small with very severe symptoms and also with severe comorbidities. And also, there are many issues still about whether these patients should be sent home on the same day, but more about that later. So obesity, we could have a whole talk on obesity, but we don't have time for that. Internationally, prevalence rates are up to 24%, and it's sort of plateaued in developed countries, but developing countries are seeing a rise in obesity, which will have a knock-on effect for the adults in the next generation. In Singapore, the most recent prevalence that was stated in 2017 is 13%, so it's not insignificant. Drug dosing is probably the one important consideration that we're all concerned about, knowing whether to use total or ideal or lean body weight for our calculations. One suggestion if you're using TIVA is that you can use the ideal body weight plus 20% for the calculations. Of course, it may also depend on what TIVA protocol you may be using. And another drug that may be effective is antibiotics. You may be potentially underdosing the patient as well. So other pediatric issues, we have syndromes. Down syndrome is probably the commonest one you'll see, but of course there are many rare ones with airway issues, sequences such as Pierre Robin mentioned. We also have very small babies now. And this little fellow here, he was born at 21 weeks, 2 days at 340 grams. And he just celebrated his first birthday in June this year and made it into the Guinness World Record book as the youngest baby to have survived. And of course, other pediatric issues are special needs. And of course, in ENT, hearing impairment is a big one that we must consider. Some of them, we are treating them at the very beginning, but some of them are also along their journey. So we have to consider their needs as well. And of course, we need to consider autistic children who have their own needs and can come quite frequently for many different procedures. So bread and butter ENT ops, which you probably most of you will do, is myringotomy and tympanoplasty, tube insertion, and myringoplasty, mastoidectomy, and even cochlear implant has become almost ordinary these days. For the nose, it's a lot of electrocautery for bleeding, radiofrequency ablation for turbinates, and button batteries, which I just bring up not because it's very common, but the consequences can be very devastating, so we should be aware of this. And of course, adenotonsillectomies, which I'm going to talk about next. And these are just some figures from our hospital about the most common procedures done. You can see that adenotonsillectomy is way out in the front. However, ear procedures are also there. So we have M&Ts and also non-otitis media ear procedures, including foreign body. Microlaryngobronchoscopy is also fairly common. Some of them are actually follow-up patients after tracheostomy. And we also have a fair number of nose and turbinate procedures as well as preauricular sinus. So for adenotonsillectomies, I would say that a lot of you would do them on a routine basis, and I'm just emphasizing today what you are probably already doing. So the patients who are at higher risk, we should consider very carefully whether we want to send them home or keep them overnight and observe them. In our hospital, I don't think we send anyone home on this as day surgery. Most of them are all same-day admissions and stay overnight. PONV prophylaxis is very important. So you should be giving at least double prophylaxis on dansetron and dexamethasone. Ibuprofen has been shown to be fine over a number of meta-analyses and trials. And so I think even surgeons now don't have any objection to that being given in standard doses. And of course, as we all know, codeine can be unpredictable depending on the metabolizing capacity of your patient. So, and we don't want any latent respiratory depression, so we avoid that. These days, some people may choose to use the LMA, a reinforced one. It's better described in adults rather than children. 2016, there was a survey in the UK which showed up to 16 to 22% of people said they would choose an LMA as their first choice over an ETT. However, other studies have shown that the LMA is obviously with its risks. So when the gag is put in is the most dangerous time, when the tonsils are manipulated, and also if there's positive pressure ventilation to the LMA. And of course, as a younger age, these are all higher risk factors for failing. And the fact that this study also had a failed LMA group shows that this is something that you must consider very carefully before using. The use of TIVA is now becoming more popular, depending on your institution or the people who are exercising it. So obvious advantages are less PONV, less pollution. We have newer agents like dexmedetomidine. But the problem is you need someone who's familiar with using it. And do we need to monitor the EEG, and also to be careful of how to titrate it so you don't suddenly get an apneic patient. There are other ways to deal with an apneic patient, though most of us will use the spontaneous respiratory tubeless technique. And of course, we must not forget that very good topicalization is important for this to be successful. Moving on to Thrive, transnasal humidified oxygen delivery. So these days, this is being used to help with patients who become apneic. It can be an alternative to jet ventilation. One senior ENT surgeon asked me to spread the message that they don't particularly approve of using jet ventilation these days because of the high risks that are associated with it. The effective splinting airway pressure was shown to be about 4 to 6 cm water in children, so it's not too high, but they are, compared to adults, more prone to airway collapsing and obstruction, although you can try to use it in these variously described procedures like dynamic assessments, collapse, vocal cord surgery, and cysts and papillomas in that area. However, with laser surgery, there is an increased risk. So what are the pros and cons? Well, I don't think you will have time to read through all of this, but obviously there's a time to use it and a time not to use it. A recent review in 2021, in light of the COVID restrictions, claims that Thrive has less aerosol generation than coughing, but you can read up this paper by Ridgway to find out what they say. So this is just a little table from an ENT review about new surgeries and technologies. And I think the ones that are interesting are they're minimally invasive surgeries. So there's more use of scopes rather than using the huge microscope, and also the use of balloon dilatation sinuplasty, which is being used a lot in adults. So this is a diagram just to show how the balloon is inserted into the sinus and dilated to allow for drainage rather than trying to do an endoscopic surgery. So drug-induced sleep endoscopy is better described in adults. In children, there is still an increased incidence of airway obstruction. The history of it is that people started with benzodiazepines. They went on to propofol and remifentanil infusions. Now dexmedetomidine is probably the best one, as it more closely resembles the EEG for natural sleep and also has less airway obstruction. However, the review in 2017 for Paediatrics says that generalizability of DISE in children is going to be obstructed by the fact there's no universal anesthetic protocol or scoring system, which is probably due to the fact that children come in a huge range and variety of sizes and ages. Transoral robotic surgery is also something that's coming to smaller and smaller children. So in older children, it's been well described in the use of removing lingual tonsils in the base of the tongue reduction. However, there are more papers suggesting that laryngeal cleft surgery is quite suitable to robotic surgery because everything is very deep and very small and fine. And this youngest baby in this study was 14 days old, had a saccular cyst removal, which I guess compared to a laryngeal cleft is less complicated, but it is on a very small baby. So auditory brainstem implants are the hearing aids that are used when the cochlea or the cochlear nerve is not functioning properly. Best described populations are neurofibromatosis 2 and also nerve aplasias. And these procedures are often mostly done with the neurosurgery in tandem. What will affect anaesthetists is that we need to do endotracheal tube electromyography monitoring, so cranial nerve and brainstem mapping. The one on the ETT will be looking at the vagus nerve. And you can see an example here of a case that was done in our hospital and how the green electrode was wrapped around the ETT, which is supposed to contact the vocal cords. And that you can see a lot of things get stuffed into the mouth, including other electrodes into the tongue to measure the other cranial nerves. So you have to make sure that your ETT doesn't fall out, that your wrapping doesn't fall off, and that your mouth doesn't get too full of things and the patient doesn't end up with an edematous face. The other thing about brainstem is that you must watch out for bradycardia when they stimulate. So the exit procedure is another interesting case for ENT surgery. You can see a child with a very huge floor of mouth tumor, which is filling up the mouth here, and the tracheostomy is being done as the child is half in the mummy's tummy and half out. And you can see on the right that there's a huge crowd in the room, and doing these procedures benefits very much from rehearsals. And during this rehearsal 5 years ago, it was done 2 times before the actual date. And you can see better here, the tracheostomy is already in, and you can appreciate how large the tumor is. The anaesthetist had tried to do a direct laryngoscopy, and also even a nasal endoscopy could not get past the floor of mouth tumor. So it was only front of neck access for this child. So just to emphasize that we are partners in airway management because we share an appreciation of the difficulties. We need to have very clear communication, and preoperative huddles are very useful for this. We are part of the leadership that should be part of the airway lead, which, has been recommended in the NAP4 report. And our role is to disseminate knowledge, lead quality improvement initiatives, and collaborate with other specialties so you can increase the standard of care. We also mutually support each other in educational movements. So this is our pediatric airway ventilation workshop we've done with our ENT colleagues for the last half decade. You can see there's one very important point in our KAICO algorithm, and that is the ENT person available or not? So we work very much hand in hand. If they're not around, you may want to attempt front of neck catheter insufflation with great caution. The study done from us department showed that you should keep oxygen flow rates as minimally as possible. So 1 liter per kg per minute, or an age plus 4 over liter per minute formula. So some examples below. For a 1-year-old, you might end up between 5 to 10 liters per minute. So COVID has transformed our practice, and there is just so much information out there. You can probably see those 2 makeshift type of airway protection devices on the right, which there was so many of them at the beginning, and since then we've realized there's a tendency to MacGyver bias, that if we don't scientifically test them, as subsequent papers did, that we may be rushing into using things that don't actually protect us or may actually hamper our ability to do airway management properly. So obviously we need to take care of our healthcare workers, and that we must make sure that the system contingencies are very firmly in place. And if you're interested in reading further advice from the ENT resource pages, these are some suggestions. And this is a little tent that was cited in a French study of the ENT Society. And as you can see, there is no real patient inside. So there's a lot of simulation and a lot of thinking going on. These guidelines from the ENT in 2020 are probably the ones which you can refer to. And some, just that list on the right-hand side is just to show how many suggestions there were. Some that are relevant to us is the use of the HEPA filter on the expiratory limb, avoid Thrive, that's too much, like more than 6 liters, and make sure that you try to avoid FOB if possible, unless it's emergent. Then also to preferably use a supraglottic airway device over bag mask ventilation, as there's less aerosol generation. And be aware there's aerosol generation with electrocautery, the microdebriders, and powered instrumentation and lasers. And that they recommend that tracheotomies should only be done after the COVID infection has been cleared. So with all these papers and information, it's heartening to know that we are actually working together as specialties to try and make it better. And a lot of people are coming out with their experience to share. And these are some papers that are quite good to review. I can't cover it all here today, but you may be interested in going back and reading them. So in conclusion, we have a lot of bread and butter cases, but our patients are not bread and butter. Some of them can be quite complex and complicated. There is much potential for innovation in our two fields, and we as two specialties can work side by side to increase that, and also as leadership in airway management, especially now that we're going forward into an uncertain post-COVID-19 era. So this talk would not have been possible without the contributions and pictures and information from many people, and I thank everyone who is mentioned in this slide. And here are some references which you may be interested to look up if you would like to go further into this. Thank you for your attention today.
Thanks, Somin, for the very comprehensive talk on ENT in anesthesia for ENT in pediatric patients. The Q&A sessions will be at the end of after all the speakers have given their talk. So our next speaker is Dr. Satish Reddy, who will be speaking on TIVA and target control infusion in pediatrics. Satish, you're welcome.
And I thank the organizers to invite me to talk on this topic. So I'll be talking on TIVA and TCI in pediatrics. I'm Dr. Satish. I work in KK Hospital and I've been there for about 10 years. So the outline of my talk is going to be that basically children are not small adults, and how we adapt our existing pumps to those who are 1 year old to adolescents. So when we see the usage of TIVA and TCI, so in the activity study, which was done at the same time as the National Audit Project, which looked at awareness under anesthesia, they found that about 5.8% of anesthetics were under propofol. And TCI was mostly used in the theater, but when it came to ICU, radiology, and ED, only 80% of it was TCI, and mostly it was TIVA. In KK, we are steadily using more and more TIVA and TCI, and the last year we used about 493, which is about 5% of our anesthetics. A bit of pharmacokinetics. So the drugs most commonly used in TCI are those ones which have a steady context sensitivity half time. That is, once we give them as infusion, the time in which half of it is metabolized is not too long. So the drugs most commonly used are propofol and remifentanil, and the adjuvants used with them are ketamine, midazolam, and dexmedetomidine. So why do we actually need to learn regimes not only in adults but in pediatrics? So this graph shows on the x-axis the time and on y-axis the concentration. So at about the 1 hour mark, if we give in a 1 year 10 kg child 10 mils per hour, which seems like a good dose, we see that at the 1 hour mark, the concentration is not even therapeutic. So if we are not aware of what we are doing, we are at risk of causing awareness. So the indications in pediatrics most relevant is in patients with neuromuscular diseases, those in which who have MH risk. So in this, we have to know how to use TCI. Some of the other things which we don't give that much importance, but we should be aware that especially in transporting paralyzed patients, we always use propofol infusion. We should be aware of what we are doing. In remote locations where we are giving anesthetics, where we don't have scavenging, in order to reduce pollution, we should be using TCI or TIVA. And most common usage in KK, and I think worldwide in pediatrics, is in use where evoked potential is used, especially most commonly in scoliosis surgeries. The other minor indications in those with high instance of PONV, in airway procedures, in children with emergence delirium prior, and where we want rapid recovery of psychomotor functions. So there are a few disadvantages of TIVA over gas anesthesia. So we need venous access, pain or injection. I have highlighted bacterial contamination. We are using more of TIVA with central lines, those with Hickman lines, and in these we should be particularly careful to use aseptic precautions while drawing the drugs. Equipment-wise, again, we have seen that we use less of TIVA compared to gas anesthesia, so we may not be as aware of our equipment, and this causes the high risk of awareness. When it comes to monitoring, most of us have had minimal training in reading EEGs, so in form of BIS and now SEDLine, which gives us more information. So why do adult pharmacokinetic parameters not work in children? Very obvious is size, and second is maturation. When it comes to metabolic pathway in propofol, it's actually mature by 1 to 2 years. So what we are mainly dealing with is size. Again, back to some pharmacokinetics, we know that propofol infusions follow a 3-compartment model: V1, V2, V3, which V1 is not actually the blood volume, but it's a theoretical central volume compartment. And V is where it works in the brain. So the volume of distribution in children is more than in adults, especially the V1 volume, and because of which we require a larger loading dose. This is because the fat and protein content vary in children, and it's the fat content is maximum up at about 4 to 5 months, and the protein content gradually increases from neonate to adult values. Clearance, it's the major determinant of drug infusion rates at steady state. So after maturation at about 1 to 2 years, it is much greater in infants compared to older children and adolescents. So allometric theory is something that says basically that children are not small adults. And again, this is the formula is beyond my comprehension and beyond the scope of this talk. So when you come to TIVA in children, so most of us are aware of the 10-8-6 rule. So this was proposed by Roberts way back in 1988. So we use this in adults. So bolus of 1 milligram per kg followed by 10-8-6 going down every 10 minutes. So with this, they achieved 3.67 mics per mil, which is about adequate for anesthesia in 2 minutes, and it was stable for 80 to 90 minutes. There are some manual regimes in pediatrics proposed by McFarland for between 3 to 11 years and Stuer for under 3 years. McFarland basically worked backwards. He looked into what Kataria had done and found what will suit in a manual regime. No blood values were taken. He just mathematically did these calculations. So according to this regime, we should be given 2.5 milligrams per kg bolus, and every 15 minutes come down our infusion rates. And infusion rates are much higher at 15, 13, and 11. What I do in case when I'm doing a manual regime is I give 3 milligrams per kg, then I do 15, 12, and 10. It's much easier to calculate. Stewart did clinical studies in which to see where there was movement at what ranges and below 3 years of age, and he found that much higher doses are needed, especially between less than 6 months. But I would not advise anyone to go at such high doses. They have been shown to cause significant hypotension and bradycardia. If required in such an age group, do use a healthy dose of adjuvant. So when it comes to validation studies, in this study they looked at 66 children and they compared 4 groups in which TIVA used without BIS, TIVA with BIS, Kataria regime and a Schneider regime. They found when without using BIS, there's a higher risk of over and under dosage. So that means under dosage means there is a chance of awareness. But when we use this with BIS, there was not major difference between TIVA and TCI. But they emphasize that we need pharmacodynamic feedback in the form of processed TEG whenever we use propofol anesthesia. When it comes to TCI regimens of propofol, most commonly use a Kataria and Fuser. Kataria is the oldest regime. There are many other models. I'm not aware how many are commercially available, but Eleveld, which is a general purpose model both for adult and children, are commercially available, but I'm not sure if Singapore has it yet. The TCI models, there are none for those less than 1 year of age. Kataria is from 3 to 16 with a minimum weight of 15 kgs. Pete Fuser is from 1 to 18 years with a minimum weight of 5 kgs. And Marsh and Schneider, those used in adults, are for greater than 16, and the minimum weight is 30 kgs. Kataria model has been shown to underdose when it comes to teenagers in steady state. So I would advise either we use Pete Fuser and even Marsh and Schneider work in these age group. The CP values are almost about the same as in adults, about 4 to 6 when it comes to propofol. If you're using these models, what you should be aware of, the covariant that is the only covariant that's important is weight. The age, sex really don't matter. So for a 3 kg, if I'm not careful, I can key in 30 kgs, and even for 16 kg, I can key in 30 kgs. In Pete Fuser, for a 1 kg, I can go up even to 61 kgs, and for 18 years, for 5 kgs. So we should be very careful in keying in our weight, not to make a mistake there, and the age really doesn't matter that much. When it comes to validation studies, the few studies that are there, none of the models have been shown to be superior. In fact, the models which are not commercially available have been shown to be superior in some of the studies. But long and short of what these studies say, that whatever model we use, we should be having a pharmacodynamic feedback in the form of EEG. When it comes to the adjuvants, most commonly used is remifentanil. Remifentanil, the metabolism pathway is mature at birth itself, and the clearance is highest in neonates and decreases with age and reaches adult values by adolescents. As a rule of thumb, when you're using remifentanil in less than 5 years or maybe 20 kgs, the requirement is twice in terms of mics per kg per minute to get the same clinical effect as compared to older children and adults. The TCI models, there are some available, Rigby, Jones, and Davies. I'm not aware that are available commercially. Minto model, which most of us have it in our pumps, the minimum is 30 kgs and age is 12 years. Few precautions with remifentanil, we should not be mixing it with propofol, as separation has been shown to happen. And this Minto models, we should not scale it down to use it for much younger age groups and try to calculate in our head. So we should rely on TIVA below 12 years of age. Propofol remifentanil, most commonly used combination. So varying studies say that the anesthetic effect is either additive or synergistic. But what we should be aware that all the effects are not the same. So the patient may be apneic and patient may not be adequately anesthetized. Propofol, when used alone at the same BIS levels, has been shown to have more surgical moment to surgical stimulus compared to inhalation agent alone. So we should be using remifentanil, especially when we are not paralyzed, to reduce movement. If you are using remifentanil in airway procedures, so a useful indicator to know when we are overdosing and when we want to reduce is a respiratory rate. So when we are reaching respiratory rate at about 10, we should cut down on our doses. Ketofol, another combination use. Ketamine, as we use longer, the context sensitivity half time increases. The combination I have used is 1:5, that is 100 milligrams of propofol with 500 milligrams of 500 milligrams of propofol and 100 milligrams of ketamine. So what I calculate is when I reach about 2 milligrams per kg of ketamine and the procedure is still going on, I change the pump to a pure propofol. At much higher doses, I find that the patients are asleep for very long, and there is high chance that they'll be quite gaga after the anesthesia. Dexmedetomidine, again, increasingly used in pediatrics. TCI model is not yet available. We use the same as in adults, 1 mic per kg over 10 minutes, and maintenance dose 0.2 to 1 mic per kg. What we have seen is children actually can tolerate quite high doses without going apneic. Some of the practical issues with TCI and TIVA in pediatrics. Propofol pain, if you use a 24 gauge, almost 100%, 22 gauge, also very high incidence. So use large bore cannula as far as possible and in a proximal vein. Medium triglyceride propofol causes much low incidence of pain. And if you have remifentanil infusion for about 2 minutes at 4 nanogram per mil or about 0.1 to 0.15 mics per kg per minute will reduce. What helps is telling the parent and patient that there will be some pain, and telling the parent patient might move because of the pain. And also our AU nurses very kindly massage the vein, and which I find very helpful. We are seeing more and more obese children, and it's quite difficult to calculate what exactly we should be doing. The lean body weight, if we take, is actually will be too less, and if we take total body weight, it will be too much. Has been shown that if we take total body weight, they will require a much lesser dose. So what we should be doing probably is be taking a weight somewhere, keying in a weight somewhere in between the lean body and the total body, and definitely using EEG in these patients. For special needs children, they have been shown to require much lesser dose, even with inhalation agents, about 10 points less. So we should be using BIS or Sedline with these patients. Propofol-related infusion syndrome, apart from allergy to propofol, another thing that we are quite scared of, almost exclusively seen in children. But luckily for us, most of the incidence is in ICU, and there are very few case reports in theater. But in case we really have to use in theater, what we should be aware, it happens with prolonged usage, with high propofol usage, with low sugar intake, and when these patients are sick. So if we are actually picking up a patient from pediatric ICU, we should try not to use TCI or TIVA. And in case we really have to use, we try to minimize the usage of propofol by using adjuvants, regional anesthesia. And we should be monitoring glucose and giving glucose supplement in case they're hypoglycemic. Mitochondrial disease, it's said to be high risk of propofol-related infusion syndrome, but it's not really a complete contraindication. But what's been said in this review of is that we should avoid prolonged usage of propofol. Lastly, I'll be talking about awareness with TIVA and TCI. So I'll be concentrating mainly on use of both volatile agents and propofol infusion. And in the activity study, they've shown that there's a disproportionately very high instance of accidental awareness when both the agents are used. So in pediatric, it's very common. We don't have an IV plug, but we inhale them down and then we convert them to propofol infusion. So chances of this happening is much higher in pediatric age, I feel, than in adults. So a very useful guidance by AAGBI and Society of Intravenous Anesthesia. What they say is, in case we are moving from inhalation to TCI, we should be giving a good bolus, a bolus that's equivalent to anesthetic dose, say about 4 microgram per mil. Yes, we are all aware that the anesthetic agents will linger for some time and patient may get hypotensive. So once this bolus dose is reached in about 60 to 120 seconds, we can cut down to 2 to 3, and we should always be using the guidance of processed EEG in form of BIS and SED-line. So in case I'm called to SARC 10 years later, hopefully we'll have some more updates. I may be recycling the same slides, but I may be talking, in case we have more progress in TCI, I may be talking about general purpose propofol models. They are available commercially, so for all age groups, so we don't need to use different models, but hopefully it will be available in Singapore and KK. We may have FX side models even for pediatric. Exhale propofol concentration, propofol metabolites are found in exhale breaths. So we may find a way that of monitoring them to find effective dosage. We may have processed EEG, BIS and SED-line, which for all age group at present not really useful, less than 1 to 2 years. And there may be, again, effective closed loop TCI models. Thank you very much, and I'll invite you all to attend the ASPA 2021 Asian Society of Pediatric Anesthesia to be held on 13th and 14th of November. It's free registration and abstract submission. We have a complete track on TCI and TIVA, and also industry experts to talk about processed EEG, how to read SED-line and this. Thank you very much, and I welcome questions at the end of this track.
Thanks, Satish, for your talk on TIVA and TCI in pediatrics. It was really very interesting. Our next speaker is Shuing, who has very kindly taken time out of on her birthday to speak on updates in pediatric regional techniques. Shuing, please take the stage.
Good morning, everyone. Today I will be giving some updates in pediatric regional anesthesia, or PRA for short, in the last 5 years. We do know that the same medical treatment for children do not always progress in tandem as adults. Therefore, I believe it is a timely thing to do a review of this topic today. The scope of this update will be presented through my pick of 5 articles from the last 5 years that will cover the trend of ultrasound, safety of PRA practice, consensus practice guidelines, innovations of block techniques, and the impact of RA on enhanced recovery of the pediatric child. So starting with trend, one might argue that the push for ultrasound-guided blocks has always been a more intuitive rather than evidence-based one. The use of ultrasound for pediatric blocks has been evaluated from as early as 2010. And nearly 10 years down the road in 2019, we now have our much awaited Cochrane review reported in this article number 1. Included in this Cochrane were 33 well-designed studies with a total of more than 2,000 children, where ultrasound guidance was compared with another method of nerve localization, and the aim was to determine whether ultrasound guidance decreases failure rate or the rate of complications. And these were the primary and secondary outcomes. Comparing efficacy outcomes on this slide between the no ultrasound group versus the ultrasound guided group. Ultrasound guidance reduces the risk of failed blocks by 0.16 times, and that translates to a number needed to treat of 6 to show the difference. When ultrasound guidance was used, there's a small to moderate reduction in pain 1 hour after surgery, and block duration was also prolonged by equivalent of 42 minutes. There is, however, very little difference in the time needed to perform the block or the number of needle passes. Moving on to outcome measures related to safety, neither the intervention nor control arms of the trials reported any major complications, namely cardiac arrest from LA toxicity and lasting neurological injury. There was also very little difference in minor complications such as bloody puncture, transient neurological injury, seizures, or blood infections without neurological injury. So in summary, the results are encouraging and consistent with prior reviews, justifying the widespread use of ultrasound in peds and not just in adults. However, looking at the last slide on safety outcomes, there is still not enough information to determine if ultrasound guidance could help reduce complications from RA in children. Due to a fortunately extremely low incidence of major complications, it's probably not worthwhile doing a randomized controlled trial to demonstrate whether ultrasound guidance makes a difference or not to the risk of major complications. Instead, perhaps a large prospective observational trial might be the best option, which then brings us to my next article, and that's article number 2, which reports a happy trend for PEDS RA. Long time ago, practicing regional blocks under GA was perceived as a risky practice. But in this article in 2018, Walker et al. Reported an analysis of more than 100,000 blocks performed in more than 90,000 children. This data was collected from the Pediatric Regional Anesthesia Network, or PRAN for short, which is a multi-center database of all the pediatric blocks collected from more than 20 children's hospitals in the US. In this prospective multi-center cohort, there were no cases of permanent neurologic deficit, and the transient neurologic deficit rate was also very low at 0.024%. The incidence of LA systemic toxicity was even lower. Comparatively, the risk of permanent neurologic deficit is estimated to be about 0.01 to 0.04% for blocks in adults. 93.7% of blocks in this study were placed under GA in children. The risk of neurologic complications or severe LA systemic toxicity was actually lower for the group under GA compared to the awake group. Given that the risk is also higher in older children more than 10 years old, one might wonder whether age could be a confounding factor. But the fact is, this higher risk in the awake group persisted even when adjusted for age. Therefore, the conclusion is that regional blocks can be safely done in children under GA. Complications rates are low. However, a high index of suspicion is still warranted should there be unanticipated motor blockade, as most PRA are performed for analgesia rather than as a sole anesthetic technique, and LA concentrations used are usually lower. Moving on, the next 2 articles are on consensus advisories. Article number 3 summarizes 2 recent sets of ESRA and ASRA practice guidelines for PEDS regional blocks. This arose from ongoing debate regarding crucial issues concerning the effective and safe conduct of PRA. Now, the background was a lack of consensus in PRA practice since 1980s, until the European and American Societies of RA in 2012 decided to set up a task force, and they chose 7 individual topics covered in 2 separate publications, 4 in the first and 3 in the second. Each topic went through extensive literature search, were reviewed by PRA experts, and presented using an evidence-based grading system. I will now present the key points from the first set of guidelines published in 2015. The first key point is that the use of test dose is discretionary. This is because a negative test dose is difficult to interpret, as GA can actually blunt the hemodynamic effects of epinephrine. However, a positive test dose, often seen as tachycardia or T-wave changes, must be interpreted as real unless proven otherwise. Therefore, we should actually be injecting local anesthetic in very small aliquots of 0.1 to 0.2 mL per kilo with intermittent aspiration and observing the ECG. Imaging modalities, where available, could be considered to visualize and to avoid accidental intravascular injection. The next key point with regards to loss of resistance technique, it states that there is no strong literature of supporting one technique over the other, but the important thing is to keep the injected volume minimum. Consider a combination of air and saline. because it minimized the risk of injecting air and reduced the volume of saline injected. This method is also associated with a lower risk of unintentional dural puncture. And in neonates, if the loss of resistance to air technique is used, definitely limit air to less than 1 mil and avoid multiple attempts. The consensus statement also have something regarding acute compartment syndrome. It states that it does not delay diagnosis as it is not reported in the PREN study, which reported for more than 100,000 children. There are, however, reports where peripheral nerve blocks have masked ACS in adults. Therefore, frequent clinical monitoring and early review in the event of breakthrough pain, especially when analgesia, including regional block, has been previously effective, must be performed, especially following high-risk injury like a comminuted tibia fracture. The advisory suggested limiting the LA dosing to low concentrations and low volumes and avoiding adjuvants in blocks for high-risk surgeries. The second set of published guidelines followed up with recommendations for LA and adjuvants. This is extremely useful because there is a wide spectrum of age and size of children, and it calls for more than a simple knowledge of standard perineural dosing. Hence, this slide is purposefully busy to demonstrate that PRA dosing is nothing but standard. However, the guidelines did attempt to give a good summary in 2 points. The take-home message is that PRA dosing for LA is usually in low concentration for the purpose of analgesia rather than anesthesia, and they are in small amounts to avoid chemical toxicity to small nerves. Bolus and continuous LA dosing are by weight. And there is, however, some controversy over the maximum ropivacaine dose. ESRA recommends a maximum dose of 2 mg per kilo for ropivacaine, but this is disputed by another PRA expert that recommended a max of 3 mg per kilo. In response, ESRA's explanation was that the CYP system subtype that metabolizes ropivacaine and ropivacaine matures at different ages. Therefore, ropivacaine is metabolized, which is metabolized by the CYP subtype of 3A4, reaches maximum clearance at 12 months of age, whereas ropivacaine is metabolized by a different subtype and may not reach maximum clearance before 6 to 8 years. The final key point for this second set of recommendations refers to use of adjuvants for PRA. At the time of publication, most of the evidence goes for clonidine as an adjunct for both neurexia and peripheral nerve blocks in children. Clonidine is selective for alpha-2 adrenergic receptors located in the central nervous system. It also acts on peripheral nerves by blocking the A and C fibers and causes vasoconstriction to slow down elimination of LA from its intended site of action. Dexmedetomidine, also an alpha-2 agonist, is recently described in literature. It is 7 times more selective than clonidine, which means its analgesic and sedative properties are more potent too. Safety considerations therefore include potential for hypotension and bradycardia. In fact, at this point, it is very prudent to say that because toxicity data in children is very limited, the minimum dose needed to achieve its effect should be used. In fact, a disclaimer in the guidelines warns that none of the drugs mentioned are registered for perineural use in peripheral nerves. Therefore, ultimately, their use again remains discretionary, and the practitioner should sort local guidelines if there should be a dispute. Moving on to innovations in block techniques. This article focuses on the ultrasound technology that has enabled anesthetists to perform a new generation of truncal blocks defined by myofascial planes. They are no longer discretely viewed nor defined by tactile endpoints, but can be seen clearly on the ultrasound. 3 have garnered recent attention, in the pediatric population, and they are the quadratus lumborum block or QLB, erectus spinae block or ESP, and the serratus anterior plane block SAPB. The QLB and ESP blocks are essentially considered as paravertebral blocks by proxy. The needle does not enter the paravertebral space, but LA spread into the space, acting as a depot, giving a more prolonged and wider spread. The advantage compared to an epidural is that these blocks are less invasive. They provide unilateral blockade and avoid undesirable side effects like motor weakness and urinary retention. 4 different approaches have been described for the QLB. The first 2 involve depositing local anesthetic superficial to the QL muscle. Now we can see the QL muscle here. Type 1 involves LA deposited lateral to the QA muscle, type 2 posterior to it, and type 3 is the transmuscular approach, where needle is passed through the QL muscle and deposited between the psoas and the QL. And finally, the 4th type, where the LA is deposited intramuscularly. The significance of this is that different approaches of QLB seem to have different analgesic effects and mechanisms of action. In particular, transmuscular QLB and QLB2 may result in wider and longer sensory blockade. The intramuscular approach produces less paravertebral spread and is therefore less efficacious. The pediatric evidence for QLB is mainly for lower abdominal, inguinal, and urological procedures. Suffice to say that the type 2 QLB and the transmuscular QLB are seen to be more effective in reducing pain scores, if not similarly efficacious to techniques such as gold standard techniques such as Cordal. The use of QLB continuous infusion has also been described in children for the purposes of radical nephrectomy and colostomy closure. Besides QLB, the erectus spinae block or ESP is also described as the other PV paravertebral block by proxy, where the local anesthetic is placed distal to the paravertebral space, but proximal to the intercostal plane in the thorax and the TAP plane in the abdomen. This ultrasound image demonstrates the performance of ESP in the parasagittal in-plane technique. You could see that LA is injected between the erectus spinae muscle over here, and there is a hydrodissection of the muscle from the tissue fascia plane at the level of the transverse process. The targeted vertebral level for injection varies according to the level of surgical incision, and contrast studies as well as cadaveric studies have demonstrated multiple vertebral level spread with infiltration of the paravertebral space as well. So in this retrospective analysis of 164 patients published by Adrian Bosenberg in 2019, it states that ESP allows for spread of at least 5 dermatomes when local anesthetic of 0.1 mils per kilo per dermatome could actually was calculated. This is compared to a median volume of 3.4 mils per dermatomal level suggested for dermatomal spread in ESP in adults. The block has been performed for a broad spectrum of surgeries involving incisions from T1 to L4. It ranges from, as reported in case reports, for posterior chest wall surgery, thoracic surgery, laparoscopic cholecystectomy, nephrectomy, and even lower abdominal and inguinal hernia repair in premature infants. Finally, the serratus anterior plane block has also been recently introduced into the pediatric population following its success in adults. This block provides reliable dermatomal anesthesia at the levels of T2 through T6 of the ipsilateral hemithorax. In the context of systemic heparinization for cardiac surgery, the serratus anterior plane block is a good alternative and safer compared to neuraxial or paravertebral block. Within the same article, the role of central neuraxial blockade is not forgotten. Established techniques such as the infant spinal anesthesia, underutilized in the last 20 years, are experiencing a revival. The impetus has been the concern regarding potential long-term neurocognitive effects of GA in young child. These techniques have expanded from single-shot spinal anesthesia to combined spinal epidural technique to provide a prolonged anesthesia under the level of the umbilicus and therefore avoid the need for GA. This slide brings us to our last article summarizing how RA can make an impact on patient outcome through its role as one of multimodal anesthesia and contributing to enhanced recovery after surgery in children. The concept of ERAS is that multiple evidence-based interventions can be combined into a protocol to act synergistically to improve outcomes for patients. Over the past 20 years, ERAS programs have been found to reduce length of stay complication rates in adults, but there has been very little pediatric data on this. Therefore, this last article in my best picks affirms that regional anesthesia role in enhancing recovery in post-op children cannot be ignored. In this article, an example of pediatric ERP for colorectal surgery adapted from adult guidelines is shown. 19 of the 21 adult elements, including regional blocks, were included in this ERP for children. The result was a reduction in length of stay, earlier return to regular diet, less use of opioids, and volumes of fluids given during surgery. In essence, this pediatric protocol makes recommendations for the standard anesthetic regimen, but goes further and specifies goals of regional anesthesia given prior to incision and post-op for opioid-sparing effects. Further, regional anesthesia may decrease intraoperative requirements for GA drugs, provide more rapid awakening and early extubation, and also attenuate the harmful effects of a surgical stress response. With this, I have come to my last two slides of take-home points through my 5 picks of PRA papers from the past 5 years. That regional anesthesia under GA is safe, ultrasound makes it better, test dose is discretionary, a combination of air, saline for loss of resistance technique and epidural works best, regional anesthesia does not delay diagnosis of ACS. Clonidine works as adjuvants for both central neuraxial and peripheral nerve blocks. The newer plane blocks works just as well in children, but do not give up on old drugs and techniques. And finally, regional blocks improves outcomes in the pediatric surgical child. Thank you.
Thanks, Shuing, for a very clear picture on the updates on the pediatric regional anesthesia. Now, our last speaker for this session is Dr. Serene Lim, who has got over 2 decades of experience in managing pain in pediatric patients. I invite Serene for her talk on pain management in pediatric oncology. Dr. Serene.
Good afternoon to one and all. I'd like to thank especially the organizing committee of the 5th SARC for giving me this opportunity to share my knowledge and experience on managing pain in the pediatric oncology patient. This is a subspecialty that's not for the faint-hearted. I'd like to start by saying I have no disclosures, and to paraphrase Oscar Wilde, I have nothing to declare except my sincerity. Now, the impact of pediatric cancer is pretty much like a tornado. It hits hard and fast. It can be very disruptive to the entire family, making high demands on finances, time, and resources. Medical therapy alone is not enough. To be a truly holistic physician, one needs to spend a day walking in this patient's shoes. Holistic multimodal approach to analgesia works best. We aim to maximize comfort and the quality of life. We need to have a fundamental understanding of the challenges with dealing with the pediatric patient, the pediatric cancer itself and its characteristics, and the pains involved. Identifying the really painful condition allows us to be proactive and timely in our analgesic interventions and escalations. I will also be talking about when pain meds don't work, regarding opiate tolerance versus a worsening disease picture. Touching briefly on complementary alternative medicine and what is helpful and what is not. And at the journey's end, what makes a good death and how to work towards that. In terms of a holistic approach, it's important to keep an eye on the big picture. And we need to be empathetic physicians building rapport. And we need to be sensitive about timing, breaking bad news, saying the right thing. So cancer, pain, and death, a lot of things are left unsaid. And to be a good physician, you need to be sensitive to be able to build the rapport in order to introduce the concept of a good death. Okay, communication is also very important, and broken telephone lines lead to disruption in the stream of care, especially if we work in different silos, and that can inconvenience the patient. So there's a lot of diversity, challenges, and problems in the pain and complexity itself. The limited pain experience that the child has with his age, and also different pain expression, behavior, and personalities. Some patients may be more forthcoming and others may be more reticent. Of course, parents can also bring into the picture direct conflict, lengthy debates, and indecisions. And physician conflicts in terms of the direction treatment plans are going may also contribute to confusion and a less than optimal care. So the bottom line is to approach with sensitivity and caution, and be aware that the best intentions are not enough. You have to be quite circumspect. Typical journey arc is fraught with pain everywhere, from the acute presentation down to the remission and of the disease, with possible relapses in between. As the child journeys towards the end of life, there are very diminished reserves and there's frailty. So care again needs to be sensitive and context-based. As a physician, one wishes to be a positive influence, and we must remember primum non nocere. First of all, do no harm. And on the whole, the treatment should not be worse than the disease. So we all know that there's diversity in pain tolerance and coping skills. So as a physician, it's important to try to steer the patient in the right direction, to encourage a positive outlook, to build resilience to pain, to make sure that each hospitalization is as atraumatic as possible, so that subsequent hospitalizations are not looked upon with such dread, and there's maximum cooperation. Once there is acceptance, then we can move forward into something more positive about doing the best for the patient. It's also very important in pain therapy to have a motivated patient. One does not achieve good results if the patient passively sits there and expects the doctor to dish out the pills to help him, to help his pain improve. So it's important to motivate the patient in his own journey to cope and control his pain. It's good to set short-term goals. And the autonomy or the option to make an informed choice is very important in patient satisfaction. So the duties of a pain physician anesthesiologist is to manage both the procedural and iatrogenic pain as well as anxiety, to plan and optimize the therapy, to manage side effects, to inculcate good pain management practices, and to especially avoid analgesic gaps, including end-of-dose failure, to educate and encourage pain advocacy, and good pain coping skills and safety, and to coordinate perioperative care. We also help to facilitate their re-entry into school life and readaptation through the enlistment of the ancillary support staff. Always remember to comfort and encourage always. And in the East, towards the transition towards the palliative phase and end of life, we try to aim towards positively adding life to days and not simply days to life. A lot of the misbeliefs and misconceptions result in failure to recognize the child is in pain and therapeutic or inadequate pain relief. So things that are listed here, including fears of the opiate side effects and platitudes and lies, all of these don't contribute positively to the pain experience. Basically, all medicine has the potential to be poison, and we need to be mindful of the dose as well as the patient characteristics in order to make an informed calculation and choice of drugs. Even water, which is essential for life, can be a poison if taken in large quantities. So how can we do better? It's interesting to look at TED Talks, and Dan Ariely is an excellent speaker. He had 70% third-degree burns as a teenager, and then he was subjected to burns dressing changes. So let's take a poll. Do you think fast ripping, short duration, high intensity is better, or slower ripping, longer duration and low intensity is better? Well, it turns out he was always pleading for a slower, gentler removal, but the nurse was always insisting that shorter, faster is quicker is better. It gets the job done. It's less painful for both the patient and for the nurse who gets upset and stressed by the distress of a screaming child. So it turns out later he comes back and does pain experiments in adults, and actually the truth of the matter is a slower, gentler ripping that takes a bit longer is actually better in terms of stress and perception of pain. So we have a lot of preconceived notions. And then in terms of this drug, xylocaine, we all know that it's a local anesthetic agent, right? Is this good for burns? Should we spray it on before dressing change? Yes or no? So the answer to that question is that it also contains 95% ethanol or alcohol, and it is only recommended for mucosal anesthesia and not to spray on raw surfaces. So it's acutely painful on raw surfaces. So if you spray it on burns dressings expecting to have a very grateful patient, you'll have the converse. They'll say that the spray is even more painful than the burns itself. So the same for lignocaine patches, and these are not supposed to be put on non-intact skin. They hurt, but if you put it on intact skin along the intercostal nerves, if you have shingles at the thoracic area, they actually afford quite good relief. Now, cancers, not all of them are the same in terms of the disease prognosis and the projected journey and the therapy. A good philosophy is to prepare for the worst and hope for the best. In Singapore, had estimated the incidence of about 90 to 100 new cancers diagnosed each year. It has increased from 30 years ago, and although pediatric cancer is fairly rare in the sense that it constitutes only 1% of all cancer cases, almost 50% of newly diagnosed cancers occur in younger cohort, aged 0 to 5, and present late. It is also a leading cause of death in children, second to trauma. The good news is that it's better response to therapy, better 5-year survival rates, and survival rates have improved. But they also have a shorter latency and more rapid growth. Now, the commonest childhood cancers are the hematological cancers, leukemias, lymphomas, followed by the brain tumors, retinoblastomas, and the germinal tumors, Wilms tumors, and germ cell tumors. Those that are less remedial to treatment and are more invasive and produce a lot of pain include the neuroblastomas and the bone cancers, osteosarcomas. This is different from adults, in which the top 3 cancers in females are breast, colorectal, and lung, and in males are colorectal, prostate, and lung. In terms of cancer pain, not all cancer pain is the same. In a survey of our pain service from 2011 to 2017, most of the referrals that the Children's Pain Service had from the oncology service were actually related to severe pain from neuroblastomas, hematological cancers, including mucositis from chemotherapy, and osteosarcomas. In terms of adults, some of the cancers associated with more pain are prostatic, esophagus, and advanced multiple myelomas and sarcomas. But cancer pain expression is very variable. In children with cancer, pain is a presenting symptom in 62% and rated as moderate to severe in 86.8%, highly distressing by 50%. The most prevalent symptom in 84.4% of the inpatients is pain. Outpatients seem to fare a little better. Origin of the pain can be iatrogenic, anticipatory pain, which is especially common in younger children, bone pain, pathological fractures, and advanced metastatic disease. It is often not a single entity, and more than one type can exist, often with a neuropathic component, and can be very challenging to control, especially as the disease progresses. In terms of pain mechanisms in cancer, it's very diverse. You can have a pro-inflammatory state with peripheral sensitization and wind up with a lot of pain mediators, including neurokinin and substance P. There's also changes in the higher centers and descending inhibitory or excitatory pathways to affect pain modulation and behavior, and also aberrant peripheral amplification through the NMDA receptor. And you can see that some of the medicines that we use actually target this NMDA receptor, for example, ketamine. Increase in the wide dynamic range neuronal excitability in response to mechanical, thermal, electrical stimuli can actually alter sensitivity, and you can have a lot of neuropathic pain and allodynia. Both depression and increased anxiety, which is common in cancer, can adversely affect pain. Now, in terms of neuroblastoma, we have this new therapy, which is anti-GD2 immunotherapy. And this is actually a monoclonal antibody infusion used to target tumor cells. Major toxic effect is neuropathic pain, and with abdominal pain and diarrhea. So we often do a proactive, preemptive protocol to reduce pain or prevent pain in this cohort of patients with PO gabapentin at night, 5 to 10 milligrams per kilo, started 3 days prior to therapy, and start opioid therapy before the infusion of the anti-GD2. Pain tends to peak on the 3rd day of therapy, so we don't wean or cease opiates prior to this, and is expected to diminish but does not always do that. And we provide a prescription if pain persists after cessation for home, which is usually morphine 0.2 to 0.4 milligram per kilo, Q4 to 6 hourly for about 3 days. So you can see it's very different in terms of the right column. Variable analgesic needs can be just with oral opiates, bolus early NCA, basal infusion, or both. In terms of the common painful conditions, burns, blistering diseases are very, very painful, as well as those involving teeth and bone. Anybody who's ever had a toothache will tell you that. Metastatic disease with its pressure effect and invasion of nerves and musculoskeletal and other visceral structures are also very painful. Anal and perineal lesions are also very painful. Surgeries involving thoracotomies, upper abdominal cavities, and diaphragm, spine, hip, knee are also very painful. Okay, so as I said, it's a mixed entity, and I'll be talking a little bit about the different types of pain, from inflammatory pain, bone pain, as well as phantom limb pain. Mucositis is very common post-chemotherapy and radiotherapy. And this, when it's very severe, can affect dental hygiene, hydration, nutrition, sleep, and rest. So when it comes to a grade 3 and 4, it's invariable that the child will need a parental type of opiate. And the best and most on-point prescription would be a PCA. Okay, so when do we treat? When the pain is severe, when there's request for analgesia, when it interferes with function. It's very, very simple. It's not just a pain score, it's also about function. Okay, what do we use? We use topicals, local anesthetic containing gargles, Diflam, Avilocaine, 2% viscous lidocaine. A lot of the problems is that it's unpalatable and bitter to the child. Opiate analgesics, in terms of bismorphine, sometimes it's also opiates through the Rouse tube. Having a Rouse tube reduces mastication and allows supplementary feeding and hydration, so that can actually reduce pain as well. Once the total white normalizes and the inflammation and infection resolves, the pain also diminishes. So that's very important. A lot of the effect on the platelet cell counts usually preclude the use of an NSAID. In terms of abdominal pain, the causes are iatrogenic, tumor-related, organic, and functional. Pain pattern can vary. So when it is very intermittent and it is unpredictable, the best would be a PCA, which is there 24/7 for the child to access, or NCA where the nurse can press for it. Bear in mind that opiate analgesics may worsen ileus and distension. And when pain is really severe, we can actually add a ketamine infusion or clonidine, which reduces the pain. Other non-pharmacological methods are also important in the treatment of pain. In terms of cancer bone pain, it can be various complex in nature with a variable pain pattern, and these are some of the adjuvants that may be required: lignocaine, ketamine, clonidine, nerve blocks. Okay, I'm running short of time, so this is some of the therapy that's used in cancer bone pain. In terms of phantom limb pain, this often occurs after amputation. About 76% of patients reported it at St. Jude's Research Hospital, but with the advent of preemptive gabapentin, this has reduced in incidence. Okay, and non-pharmacological therapies include mirror box therapy. Okay, so basics of good management. I won't go through pain assessment, but that's a key cornerstone: frequent and accurate, with the appropriate appropriate tools, and the pain treatment modalities will be multimodal. We don't use regional blocks a lot in pediatric patients, but it's possible to reduce pain that way. Okay, PCA with the analgesic in the analgesic corridor, and NCA have been used with these drugs. And typical PCA settings include this. NCA settings for safety would include a slightly longer lockout and limited number of presses. And they have been proved safe modalities of analgesia in children, provided that effective monitoring and institutional guidelines govern prescription. Okay. In terms of symptom management, pruritus, nausea, vomiting, giddiness, urinary retention, constipation, things that we should also help manage. Low-dose naloxone may be useful for pruritus and nausea and vomiting and urinary retention. When converting opioids or rotating opioids, it's important to have an idea of the total 24-hour dose as well as the equivalent dose of the opiate, of the alternative opiates. And these are some of the opiate conversion tips. 24-hour oral morphine equivalent divided into the requisite doses, either Q4 or Q6 hourly dosing. And we always need to cover with a breakthrough pain or inadequate analgesia. And there's usually a 25 to 40% reduction for safety. Okay. In terms of opiate formulations, there's sustained release opiates, but usually these are difficult in children who cannot swallow, either the neuroblastoma patients or those who have advanced disease impacting on their conscious level. So when pain meds don't work, we often use intravenous ketamine and clonidine. The reasons why opiates don't seem to work is either severe disease that's progressing, inadequate prescription, opiate tolerance, or hyperalgesia. So these are the main points to note about these would be to actually use multimodal non-opiates adjuvants like ketamine and clonidine to improve the analgesia. We often use ultra-low dose infusions of ketamine and clonidine infusions, either as a continuous or intermittent infusions. And methadone, which is a potent long-acting drug, we seldom use, but we have done in cancer pain that's really difficult to treat conventionally with PCA and NCA. Okay, the main thing is to start low and go slow. There's a sliding scale to it, and there's a maximum dose in children. We do not go beyond 0.4 milligram per kilo per dose. Okay, lignocaine patch has been useful in certain situations, especially where it's the bone is very close to the skin. And lignocaine infusion is useful in certain refractory pain states, especially if in certain abdominal disease. Okay, I will just touch on the non-pharmacological pain meds. Sorry, I'm a little bit overrunning. Complementary alternative medicine, either in TCM, Chinese medicine, Ayurvedic medicine, has come to the fore of late. Of the mind-body interventions, hypnosis and relaxation have been useful in reducing procedural pain, and manipulative and body-based methods massage contribute to well-being. Also, acupuncture has been studied, and it's useful for symptom management, for example, nausea, vomiting. It has ameliorated pain from certain conditions, muscle tension, musculoskeletal problems, migraines, fibromyalgia, and even in CRPS. It's unclear the effect on peripheral neuropathy, but it has been used to expedite the recovery from Bell's palsy. So overall, CAM use has increased. We have to be aware of that. There's also the psychosocial aspects where we need to counsel, provide spiritual support, comfort care, dealing with grief and bereavement, and also support the family. So at the end of life, there's a lot of fatigue, loss of energy, dyspnea, loss of appetite, and reduced intake, pain and increased somnolence, discomfort, and inability to lie flat. And anesthesia and procedural sedations are often risky. It's best to be honest and forthcoming with the risk at the end of life, and to afford a sympathetic and empathetic approach. So most of the patients will wish to die at home surrounded by loved ones. Only 30% manage to. So it's important to plan properly and to offer the patient suggestions and options. There's also, you need to be mindful of healthy siblings exposed to the dying child. In terms of priorities, there's time management and allocation for hellos and goodbyes, a wish list of what to do, happy things that they want to do, and party planning of where to stage the last breath, how and who to be there. Okay, so death with dignity and acceptance is important. Barriers to a good death include conflict, lack of a clear direction, critical illness, poorly controlled pain, lack of support and equipment at home, lack of planning, especially transition to a hospice or transition to a intermediate nursing support, and lack of a suitable venue. Important contributors to a good death include symptom management and analgesia, communication, acceptance, meeting the family where they are, and expectation, anticipation of death, and knowing what to do and expect in that situation, and also control of the environment. So in conclusion, pain and pathology and physiological reserves can vary greatly. It's important to identify those at risk for severe pain in order to preemptively treat them. Treatment should be individually tailored. Goals of management should always be to relieve pain and towards symptom relief, as well as comfort and empathy and good communication go a long distance. So listen without prejudice. It's going to take a lot of love, and love is the answer, and God is in the details, and that is what oncological pain management is about. Thank you.
Thanks, Serene, for the lovely presentation. Now we'll start the Q&A session, and we have got about 5 to 6 minutes. The audience can type their questions in the chat box. The first question that I'd like to ask from the chat box is for Satish, and the question is, do you reduce your TIVA or TCI dosing in OSA kids presenting for TNA? And if so, what factor of reduction do you suggest? Satish.
Thank you for the question. So I don't particularly use TCI TIVA for TNAs, but if I were to use, means OSA patients who come for TNA, they could either be obese, they could not have, or they could be syndromic. So if I get obese, as I said, I'll calculate the lean body weight and increase the weight I'm going to put in by about 10% above the lean body weight and go ahead with that. In case, I'll definitely reduce my narcotic dose in these kids by about 50% and use adjuvants in the form of paracetamol and ibuprofen. In syndromic kids, again, as I said before, that they require lower dose of anesthetics. And if I'm using TCI-TY, I'll definitely use BIS or SEDline to guide my drug usage.
Thanks, Satish. But okay, Sumin, since you have presented the talk on ENT, would you like to add anything to this question?
Yeah, thanks for the question. And definitely all the points Satish brought up, besides the fact that ENT lists tend to be fast turnover as well. So you also want to be quite familiar with your ability to manipulate the TIVA. Most of our cases for TNA are in the age group between 3 to 10 years old, and that would probably require the ped fuser protocol. And as Satish mentioned, they give quite a big bolus at the beginning because of the pharmacokinetics. You should have monitoring, EEG monitoring, so either BIS or SEDline, for you to be able to titrate properly, especially if your patient is paralyzed. Now, whether your patient is paralyzed or not may depend on your surgeon's preference, but if you're paralyzed, of course, you have to worry about awareness. So please be careful if all those relate to your situation at work. And otherwise, TIVA is a great technique. It's good for the environment and also for the PONV, which is quite a problem in TNA.
Thanks, Sumin. Shuing, I have a query for you. What are the other adjuvant drugs besides the alpha-2 agonist for PRA? And which one do you consider the safest and the best?
Thank you for your question. The safest and the best is still going to be clonidine, which is what was presented and recommended by the ASRA guidelines. Dexmedetomidine is the new kid on the block, but it's more potent, and therefore you can imagine the side effects are more. You've got to look out for bradycardia and hypotension. Then the other drugs that people have used would be opioids, ketamine, and even dexamethasone. So, okay, let's talk about dexamethasone. It's there have been at least 3 randomized controlled trials that report that actually the IV dose giving dexamethasone IV gives a similar effect as giving it caudally. And the caudal dose is usually 0.1 milligram per kilo, and the IV dose is around 2.25 milligram per kilo. So actually, the ESRA doesn't recommend giving dexamethasone in caudals. And perineural and peripheral nerve blocks or intramuscularly also has not been shown to be more efficacious in reducing pain scores. So DEXA is not really recommended. Then for ketamine, again, it's been described. We used to use preservative-free or S-ketamine at 0.5 milligrams per kilo to prolong the caudal blockade. But again, now because there's concerns about neurotoxicity in infants and neonates, we don't use it now as an adjuvant in the young ones for fear of it enhancing neuronal apoptosis. Then finally, it would be opioids. Now, morphine, about 10 to 30 mics per kilo, yes, it's recommended by ESRA, given intrathecally. But fentanyl, not really. Although fentanyl is used in adults, epidurals, in children, it's not been shown to augment the effect of ropivacaine or bupivacaine. Yeah.
Okay. Serene, would you like to add anything to this question?
I think those showing is regarding single blocks, right? Not continuous blocks, because we sometimes also add the fentanyl to our continuous blocks. I did mention that for the regional blockades, we don't use it that often in cancer patients because a lot of them have deranged platelets, and also they also have immunosuppression, so they usually have low white cell counts, so we're concerned with infection. But I have observed a child that was transported back to South America when I was in Boston, where they actually had an implantable epidural. I think the important question would be that it has to be continued monitoring, a support system where the epidural can be assessed and the medicines topped up, and there's basic troubleshooting. If that cannot be done, then it's difficult. It shouldn't be done.
Thanks, Serene. This will be probably the last question, and this is for Sumin. When paracetamol and ibuprofen is inadequate, what further analgesia would you recommend for OSA kids after tonsillectomy in the ward? Ultra low dose of opioid? Query.
Hi.
Sumin.
So yes, thanks for that question. And we tend to use short-acting opioids like fentanyl intraoperatively. Just most of the time, we don't have to actually go beyond paracetamol and ibuprofen in genuine OSA children because they are quite sensitive. And also the fact that the OSA tonsillectomy is different from a tonsillitis tonsillectomy and that there's less inflammation and tissue plane damage. But if you did have to add something on top, and if they're going to be in the ward, you may consider a very low dose of oxycodone. But that would have to be monitored with continuous SpO2 monitoring and reassessed by the team in the ward.
All right.
You can also use dexmedetomidine if you have it, but of course, most of the time that will not travel up to the ward with the patient.
Okay, I can read the answer by Serene that you can also try clonidine and then ultra low dose of ketamine, less than 0.2 milligram per kg. So we have already exceeded the time given to us by the organizers. Let me say thanks to FRESENIUS for sponsoring this session and to all the speakers who took time out of their busy schedule and presented a wonderful session. I'm told that there are nearly 300 people in the audience, so well done. And for the audience and the rest of the speakers, I'll say, okay, thanks again, and have a good day, and enjoy the rest of the sessions of this conference. Goodbye. Thanks.
Have a good weekend. Bye.
Thank you.